Indian women face a largely unrecognized yet profound cardiometabolic crisis. Despite often appearing as healthy, not visibly overweight, and consuming traditionally home-cooked diets, they carry some of the highest global risks of heart disease, diabetes, and even certain cardiac death. Cardiovascular disease is the leading cause of death among South Asian women worldwide. It occurs 5 to 10 years earlier than in women of European ancestry. A major driver is body composition. Indian women commonly exhibit the thin fat phenotype, which means that at the same body mass index, they have 3 to 5% higher total body fat, which is disproportionately more visceral fat and lower lean muscle mass. This allows for developing insulin resistance and metabolic disease to develop even when the weight appears normal. South Asian women are 2 to 4 times more likely to develop type 2 diabetes. They're also diagnosed 10 to 15 years earlier and experience higher cardiovascular risk at the same glucose levels. By age 50, nearly 40 to 50% of urban Indian women have diabetes or pre-diabetes. Pregnancy often provides the first warning sign. Indian women have 2 to 3 times higher rate of gestational diabetes, and up to 50% go on to develop type 2 diabetes 5 to 10 years after delivery. Yet, we don't always follow up the women that had gestational diabetes. The follow-up care is frequently inadequate. Lipid patterns further compound the risk with a characteristic atherogenic profile of high triglycerides, low HDL cholesterol, and small dense LDL particles that are strongly associated with early heart attacks, even when total LDL appears normal. The low skeletal muscle mass, or sarcopenia, which is very common in South Asian women, further reduces glucose disposal capacity and resting metabolic rate. It worsens insulin resistance and accelerates fat gain. Weight training or strength training is just not emphasized in our culture. So thin does not equal metabolically healthy. Hormonal changes amplify this vulnerability even more after menopause. The LDL cholesterol rises, the visceral fat increases, the belly fat increases, the blood pressure goes up, the insulin resistance worsens, causing cardiovascular risk to surge in women who already begin with a higher baseline risk. I'm sure you have heard of women in your circle who died sudden cardiac death. The consequences of these changes are stark. Among South Asians, up to 50% of the first heart attacks present as sudden cardiac death, often without prior diagnosis. Women frequently present with non-classic symptoms such as fatigue, breathlessness, nausea, back or jaw pain, indigestion, heartburn that are often dismissed or overlooked. Chronic stress, caregiving burdens, cultural expectations of self-sacrifice or not complaining, sleep deprivation further accelerates disease through sustained cortisol elevation. This pattern is not destiny. It's not genetics, it's a missed opportunity. Indian women remain underscreened and undertreated despite predictable risks. So early screening, muscle preservation, so strength training, informed care around HRT, culturally competent medicine can change outcomes. Indian women do not need more discipline, they need earlier recognition, validation of their symptoms, and permission to prioritize their health. Because true heart disease prevention begins decades before the heart symptoms appear, decades before the ICU. How can we do this? Awareness, screening, validation, and action. Please let me know if this was helpful.